Good afternoon. Good afternoon, and thank you for joining us today for Inspire Respiratory Critical Care's monthly panel discussion. Today's chat will be surrounding patient self-inflicted lung injury, or SILI. Before we get started, let's go around the room and introduce ourselves. Tom?
My name is Tom Pereno. I'm a respiratory therapist here in Canada, and everyone else is not in Canada, so I'm the only Canadian representing here.
Madison?
Hi, I'm Madison. I'm a respiratory therapist at UVA in Charlottesville.
Eric?
Hey there, my name is Eric Kreiner. I am a respiratory therapist in Washington, D.C.
John?
Hey, John Ancrott, flight respiratory therapist, Advent Health, Orlando.
And Andy?
Good afternoon. Andy Klein. I'm a educator and respiratory therapist in Chicago, Illinois.
And my name is Keith Lamb. I'm a respiratory therapist at the University of Virginia in Charlottesville. So before we get started, or actually to get us started, I thought I'd kind of talk a little bit about why we're discussing this topic. So patient self-inflicted lung injury, it's not a new concept, but it's something that's sort of trickling out to everybody, I think, more frequently now. And people are starting to, it's certainly being studied more now than it ever has been. And but it should be at the top of our minds when we're taking care of patients. So for quite some time now, since the year 2000, we've started to understand more about ventilator-induced lung injury and how certain triggers, which are patient-independent to some extent, can cause these massive exaggerated inflammatory processes that go on to involve other organ systems and worsen outcomes. And some of those things that we've already talked about on some of our panel discussions and things that many of you are very familiar with started out to focus on tidal volume size back in the year 2000 with the ARMA trial by the ArtsNet folks. And then sort of has spread out to look at, okay, well, maybe it's not the tidal volume all by itself that's causing the stress and the strain and the inflammatory cascades. Maybe it's the tidal volume in relation to the size of the space available for that tidal volume. And so that has gone out to, to make people think, okay, well, how do we know what that relationship is between the amount of space available for tidal volume and the actual tidal volume? And so that sort of triggered a lot of studies and a lot of data collection regarding what we can use, and plateau pressures, driving pressures, and most recently mechanical power and energy applied to the lungs, and what causes what do we do either with a patient that's not intubated and not on a ventilator, maybe on non-invasive or high flow nasal cannula, or a patient that is intubated and on a ventilator? What do we do to sort of mitigate or minimize the amount of energy applied to the lungs, which then goes on to cause a massive exaggerated inflammatory process that then goes on to worsen respiratory failure and this vicious cycle of energy applied to the lung? So if you remember all of that, and then today we're going to talk about patient self-inflicted lung injury, which is essentially the same injury but applied, but triggered and caused by the patient's spontaneous breathing. And so that's sort of an overview of what we think that patient or PSILI is, and so that's what we're going to talk about today. So we're going to talk about. Tom is going to go into some more detail about the pathophysiology, and then we're going to talk about things intermittently, kind of sprinkled in here. We'll talk about how do we recognize that PSILI is a problem with a specific patient and individualize the care for that patient. How do we recognize that? And then finally, what do we do? How do we intervene and how should we intervene. Before Tom gets into that, though, I'm going to tell you that, and we've discussed this many times, this group off the line has discussed these issues, but most of the data that supports these notions are really found in the animal research. And so, people have taken animals and caused central acidosis so that it increases the neural drive to breathe in the work of breathing. And then in the study group and in a control group, take those animals and intubate them and neuromuscularly blockade them so that they don't have the sequela of really high drives to breathe. And of course, none of these animals survive, so there's no outcomes data collected with these studies, but certainly they do post-mortem histological evaluation and note that the animals that were sedated and paralyzed and intubated and protective ventilation was utilized had less histological evidence of injury than the animals that had a high drive to breathe and were allowed to do so. So that's sort of where we're jumping off now, I think, into people. Tom?
Yep. Very good introduction, Keith. Now, one of the concepts that I think most people are starting to at least hear of or be familiar with is transpulmonary pressure. And we learn this in school, but hopefully you work in a center that perhaps is thinking about it and or measuring it. And transpulmonary pressure represents the true distending pressure of the lungs. So it's essentially airway pressure. So if you do an inspiratory pause, you get the alveolar pressure that's there. So it's airway or alveolar pressure minus pleural pressure. This is the simplest way to describe it. This is the direct measurement of pleural pressure. And the idea that the ventilator settings that we choose to minimize lung injury, we assume that if we are using low pressures, for example, that the chance of injury is very low. And this is where the patient comes in, that if the patient has excessively high drive, there's a very nice visual that was provided in this paper. This was a study, and I'll post the links after I'm done talking about this. This is just an editorial by Art Slutsky, a very, very famous physiologist, physician working in Toronto at St. Michael's Hospital. He's in the research lab there, or the Keenan Institute for Research. And he wrote this article in 2013, so it's 11 years old, and it's fantastic. And there's two extremes being shown on this image here. You could have pressures in your lungs of up to 150 centimeters of water if you're playing a trumpet. But we don't have this epidemic of trumpet players blowing pneumos. And why is that? Because when you are blowing a trumpet, you are increasing your pleural pressure. And in this example, it's 140 centimeters of water because you're forcefully blowing through this trumpet. So not only is the airway pressure high as we would measure it on a ventilator, but the pleural pressure is also high. So you end up with an alveolar minus pleural pressure of plus 10 centimeters of water, which is a safe pressure distending the lung. So there's no injury that's occurring. On the flip side, you could have a patient on non-invasive ventilation, for example, with an alveolar pressure of 10 centimeters of water, but the patient's making a significant effort with a pleural pressure change that goes essentially down to negative 15. And when you take 10 minus a negative, you get plus 25. And these transpulmonary pressures are considered to be risk for injury, and lung injury in particular. Now, we'll probably get into later that there's also the potential when you have excessive drive for diaphragm injury. Patient self-inflicted lung injury is basically saying that this effort can further injure the lung. And then, of course, you have the other school of thought that says it could also cause mild trauma to the diaphragm. And like I said, we'll talk about that later. So this is the simplest way of describing how it could be injurious. It's just simply transpulmonary pressure. Even low pressures and high effort can cause excessive transpulmonary pressures. So the other paper that was published, and actually I'll just quickly go back to the title of this one. You can see this is ventilator-induced lung injury. It's in New England Journal of Medicine. It's a review article by Art Slutsky and Marco Ranieri, and it was published in 2013, November 2013. Again, I'll post a link in the chat And I'll apologize if it's not an open access article. The other article that described this was this paper here. The lead author is Laurent Burchard, and you have this initial lung injury that can occur. You have patients get intubated, their lungs are injured, they're looking poor, and you have capillary leaking. This is a part of normal lung injury that could be happening. There could be lung edema, impaired gas exchange, and then you have, because of these mechanisms, you have this increased respiratory drive, and with that, you can have essentially, pendolift is another complicated thing, but essentially when you have very high effort, you could be over-distending areas that are very compliant. So you might think the healthy areas are okay and the collapsed areas aren't going to be harmed because they're just collapsed, but those healthy areas can get over-distended with pendolift. And of course, the increased PES swings is the increased effort, and all of this leading to patient self-inflicted lung injury, which then worsens capillary leak, lung edema, etc. So it's this vicious cycle that has been described as the pathophysiology for how it's injuring the lung. I'll allow time for comments or questions now, because that's not too much to take in, but that pretty much describes the whole concept of what we're concerned about with patient self-inflicted lung injury.
So Tom, I know we did, in complete transparency to the folks that are on here with us as a group, we do chat before we get on here. And so we had a little bit of a chat prior to, and can you talk about some of the ways that institutions that might not measure esophageal manometry and other pressures, like how do we recognize, or what would we look at to make sure that we are not being injurious to these patients if we in fact can't measure esophageal pressures?
Yeah, and I think, this goes right down to the next item in our outline here, the signs and symptoms of recognition. I think most of us could recognize a patient who is clearly in distress. We're talking sternocleido. Oh gosh,
Sternocleidomastoid.
Thanks. I'm drinking more coffee here. Anyways, you can see the contraction of these muscles, which is not normal unless you are experiencing is a very common sign of dyspnea and, again, increased effort. However, there are many things we could do with the ventilator, and one, of course, which we've mentioned in previous presentations, I'm sure, is the P0.1. This value is available on all ventilators, and this is something that can be measured routinely. Some ventilators, it's automatic, so it's an estimate per breath, so you can just call it up on the side of the screen. The servo ventilators are like this. You could look at, again, other ventilators have a maneuver, so you could apply the maneuver. It takes a very quick moment to provide a value. And when you do that maneuver, typically you want to take 2 or 3 measurements and sort of take the average of the 3. So these are things to recognize excessive effort. P0.1, I'll quickly show another. This is just from the blog that I manage. These are common monitoring options for patient effort. So P0.1 is a very common one, highly available. 1 to 4 is considered to be a normal value. And I do have in brackets, some ventilators may display this as a negative value. So -1 to -4. However it displays it, you'll understand that 1 to 4 is considered normal. When we would consider intervening is still up for debate. Some people would say that 6 is excessive. There's some studies showing that around 7 can predict a recurrence of, or when patients are getting better and then they get kind of bad and then you have to resedate and fully ventilate them. Some studies with COVID-19 patients found 7 to be a threshold that it kind of predicted patients having a recurrence of severe lung injury and having to be resedated and reparalyzed and fully ventilated. PMUS can be predicted using the PIOC maneuver, which is a single breath occlusion. Esophageal pressure swings, of course, are helpful, and you can also measure transpulmonary pressure or dynamic transpulmonary pressure with this. The PIOC can also not only predict PMUS, but can also predict dynamic transpulmonary pressure, which would be a lung injury problem. So if I scroll up here, you can see that the PIOC here can measure a predicted transpulmonary pressure and can tell you if the value, again, it should be less than 15 to 20, but it can give you an estimate of whether or not it's excessive. And of course, this can be measured with transpulmonary pressure as well.
Hey, Tom, can you share your slides? Do you have slides to share?
Oh my goodness. Sorry about that. Hey, look at that. Let me go. I realized I wasn't sharing that. I apologize. So let me go back and I'll quickly. So P0.1, 1 to 4 is normal. Some ventilators display it as a negative value. PMUS, which is again a measure of effort, can be predicted using a PIOC maneuver. You are seeing what I'm doing now, right? Yeah. Okay.
Yes.
Perfect. So if you have esophageal pressure, looking at the swings is one way to see if the patient's effort is excessive, but you can also measure dynamic transpulmonary pressure, which isn't so much the effort, it's the potential for lung injury, right? So there's some tools that are multi-useful. This is just an effort. This is just looking at respiratory drive. And I'll give a caveat that sometimes P0.1 can be high, and sometimes the patient may not have the ability to sustain that high respiratory drive. So they may have an initial, again, P0.1 is in the first 100 milliseconds. So it may be high in the first 100 milliseconds, but then completely tapers off to an effort that's actually not that injurious. And that's why other measures like PIOC or looking at transpulmonary pressure swings, if you want to be certain that there's potential for injury, you would need more advanced measurements than just P0.1 if you wanted to be absolutely sure. But it's a really nice way to just monitor patients routinely because P0.1 is available everywhere. PIOC is a very simple maneuver on most ventilators. It's a single breath occlusion maneuver. And then you have esophageal pressure, as I mentioned. And then if you're into diaphragm thickening fraction, you can also measure that. And then what I mentioned, how the PIOC maneuver has sort of a dual purpose. It can also be used to predict dynamic transpulmonary pressure without the use of esophageal balloon catheter, which is nice because if you don't have that technology, you can just perform a quick maneuver on the ventilator and be able to estimate dynamic transpulmonary pressure, which should be less than 15 to 20. And then again, if you have esophageal pressure, you can get the same measurement directly with the esophageal balloon catheter. Sorry for not sharing that.
So Tom, I'm just wondering, so all this stuff is great when they're attached to a mechanical ventilator. And I think we can take a lot away from that in terms of keeping an eye on things, especially if we're not fully versed in esophageal manometry. But what advice would you give for our patients that are on high flow nasal cannula and non-invasive ventilation? What can we do to pick those out of the crowd?
Yeah, honestly, I think this is a real challenge that even the brightest of clinicians or clinician scientists also face. If you were to read, articles beginning of COVID when we were, a lot of effort stuff, by the way, was obviously being looked at and talked about pre-COVID, but COVID kind of really amplified it because we were recognizing a lot of patients with really severe, significant high effort. And one of the things that was of concern is that when you're applying non-invasive respiratory strategies, how do you know whether or not, again, that first image I showed you in that article by Art Slutsky, how do you know that that's not the scenario that's happening where the patient has extremely high drive with, low to moderate non-invasive ventilation settings? How do we know we're not facilitating their ability to cause or worsen lung injury? And they were dropping esophageal balloon catheters, and really, I don't know a non-invasive ventilator that can accurately do any of the maneuvers or measurements that I just described unless you have an esophageal balloon catheter. And again, with that, you probably would want a separate airway transducer to be able to calculate measurements, but it's definitely challenging during non-invasive strategies. I'll offer, I'd love to hear anyone else comment on that because it's definitely it's been a challenge.
So I've heard and read some about, we should all probably be familiar with ROX index and HACOR scores, but some of those things can be done, or those things can be done with non-intubated patients that are non-invasive support.
Yeah, and those things can predict failure, but they may not predict whether or not the patient's injuring their lungs, right? But if they're injuring their lungs, they're probably going to fail. So probably these scores that predict failure would be extremely useful. So that's definitely, I would recommend using those scores, but they don't tell you what the degree of effort is. It just tells you whether or not they're at risk for failing, which again, likely is the scenario if you're injuring your lungs. So they're probably as useful, but they don't give you the same information of whether or not there's, severe effort, or not severe, but if there's excessive effort being generated by the patient.
So it's interesting, right? I agree with everything you just said, but what's interesting to me is that a great majority of patients that get placed on non-invasive support get placed on non-invasive support secondary to what's perceived as an increase in their work to breathe.
Mm-hmm.
So if you put somebody on, if you have a patient that's in distress, you put them on a non-invasive support, their distress gets better, and then you pick up by following their ROX index or the Haycore score or both. I think that there could be some, cumulative usefulness on that way.
Oh yeah, for sure. I agree.
Yeah.
I mean, we all know that when you apply non-invasive strategies at all, most of us can tell whether or not our patients are enjoying it or not. The patient that really responds well is the one that you feel really good after you put that on, right? The patient seems to be calming down. They're not using the same amount of accessory muscle use. And again, whether or not the resulting effort and the resulting pressures you choose are still potential for injury, again, would require advanced tools like esophageal pressure. But this is where we can just look at scores that predict failure of this therapy and probably would be more useful at that moment anyways.
Yeah. Do you know anything about, have you read anything about nasal pressure swings?
Not entirely. We did some bench studies on the pressure generated during high flow nasal cannula, but not in terms of like predicting anything.
Right. So I'm just wondering, like, there are some people have looked at some non-invasive methodology to evaluate for, an increase in work. A lot of people, including myself, since the Prosiva trial, where with proning, and then if you fast forward to recently with the Awake non-intubated proning, where there are better outcomes potentially, we've sort of come to the conclusion that interventions that improve gas exchange don't all by themselves, just because of that, improve outcomes. And so a lot of people have postulated that proning improves outcomes, not just because it improves gas exchange, but it redistributes transpulmonary pressure. And I wonder if Awake non-intubated prone positioning really is a way of reducing SILI. I'm not aware of data that really drills down into that, but what are your thoughts on that? Anybody?
I mean, I'm not as you said, I'm not sure of any data, but the physiology makes sense. We know that prone positioning basically allows the areas where there's larger lung issue or lung tissue to sort of be offloaded. You're not lying on your back. You're now exposing your back, better expansion. So potentially less transpulmonary pressure could be generated. But again, that's all hypothesis generating. I don't know any solid data that suggests that that's the mechanism that is what's beneficial, but that's what most people feel prone positioning. The benefit is by minimizing lung injury. But in a spontaneous breathing patient, it's assumed that it would be somewhat similar.
Eric, do you have any thoughts on that?
I was just going to say, Eric, what do you think?
Yeah, come on, man. I'm listening. I'm quiet. So I want to kind of, I want to go back to like what Andy was saying. Like, what if you don't have all these big fancy tools, right? And we do. Like, I do have them, and we regularly use them. But we're not putting balloons in every single one of our 132 ICU patients either, right? Like it's some, you're selecting these guys, right? And so not everybody has them. And so you either at an institutional level or kind of for everybody, there is, how do I know that these things are happening without the benefit of this really, really or somewhat advanced technology, right? And I think it goes back to this idea. Well, you have some other rudimentary tools, although you're not able to quantify it, right? You may be able to kind of qualitatively assess this idea of work and work shifting, right? And it just really goes back to basic ventilator waveform analysis a little bit, right? So if you are in the absence of esophageal pressure swings, and the absence of all of these other fancy stuff. You have P01, right? You absolutely have P01. So you do have the benefit of that. Whether that effort, like Tom was saying, is sustained throughout or is even generated by something other, that drive is something other than, a mechanics based type of thing, more neurologically based or whatever have you. But what I think what I'm getting to is that, I think we understand pretty well the idea and the diagnosis of work shifting across all of the control variables, right? And, and that speaks to non-invasive ventilation too, where we kind of slip a little in terms of waveform analysis. They're not as pretty, clearly, and there's a bit more dysynchrony involved with non-invasive ventilation. But I think if you want to start at, I have nothing, and kind of answer those questions and start kind of delving in when and how can I monitor this, you start with a P01, and then you go to the dependent waveform of whatever control variable you're using, right? So if you're in volume ventilation as shown here, if you have these dips and cups or negative concavities in your pressure waveform, and you wrap this all the way back around to the equation of motion, you have an increase in PMUS, right? Because that entire right side of the equation that you had up there is fixed and or set by you. And so the only reason why P ventilator or the airway pressure goes down is because of the increase in PMUS. And what we're saying is that you can just measure the increase in PMUS with all of these fancy things, but you kind of derive it from the pictures that are drawn right in front of you. Again, not quantitatively, but qualitatively. Is my patient working? Do they have excessive work, et cetera, et cetera? And if you're using a pressure waveform, then your flow is a dependent, and that will kind of bow upwards and outwards, right? Now, it gets really difficult. How much do I allow? Do I need this to be truly exponential decay? Do I allow a little bowing? And then a little bit of that is clinical gestalt, insert eyeballs, right? Like, does the patient look terrible with this, or are they resting comfortably? And there's a little tiny bow indicating a little bit of PMUS, which I'm happy to have, as opposed to a silent diaphragm, right? And so,
I was just going to say, Eric, I think you're hitting the nail on the head right there. That once we recognize that, how much is good and how much is bad, right? That's the real challenge. Like, I think we probably would both agree, and I'm sure you would, but when you're on volume assist control and you see this in the pressure waveform, you need to switch to a pressure targeted mode, because clearly the flow is just insufficient. Where it gets really challenging is like you just said, it gets more challenging when you're looking at pressure, because you're like, you kind of want a bit of roundness, right? You want to know that the patient's doing some of the work, but it gets more challenging to determine whether or not they've, passed a threshold of what would be acceptable versus not acceptable.
Yeah. I think it is also, on the margins difficult, right? On the margins, what we're talking about, maybe not. I think it's also something, it when you see it too, right? I mean, like, if this is just completely tombstoned up and not even close, then I think you have a problem, right? I think you have a big problem. We fight this a lot. We use, we're a conventional volume house, but, out of, our, 80 to 100 patients that are ventilated throughout the course of a day, we're a 60-40, 65-35 split between pressure and volume. And we pull the lever on pressure ventilation switching over, easy. Like it's we often use it, and we get ourselves into trouble a lot, because it's a constant conversation that you have to redirect people for the surrogate for titration of pressure as not only volume, right, which is what everybody learns. I titrate pressure for a volume, and they see a huge work shift, and they see a volume that is excessively high, and their first inclination is to turn the pressure down. And we really have this conversation around self-inflicted lung injury. And hey, look, you are also able to titrate pressure and should do so, titrate this inspiratory pressure to work, right? Can you alleviate or displace or mitigate inspiratory work with this inspiratory pressure, right? And so that gets tricky, that gets tricky. And, but, I was really kind of directing right at Andy's question, and maybe for a ton of the people that are in the audience that, hey, I don't have esophageal pressure. I'm not able to measure the swings. I understand the concept, but everybody's got these, right? And it's at least a good starting point for us to say, there is the possibility of this happening qualitatively, and kind of go from there, right? If this, I'll tell you, this is one of the triggers to drop our balloons if they don't already have one incumbent from, severe injury prior to, right, where we were directing PEEP and transpulmonary pressure limitations. So, it gets really, really difficult. It goes back to, and I already mentioned it, this like lung rescue team. I mentioned it like 3 or 4
on a previous one.
Yeah, that like these guys, they're hard, man. They're difficult and they're really, really complex, especially like in like right now in everybody's want to pull sedation away, rightfully so, right? We're over sedating patients, and so the pendulum has swung way the other way, right? Just kind of in general observation, where we don't want to sedate anybody, and we end up, allowing them to injure themselves, and so we kind of got to figure that point of it out, and these patients become really complex and need additional assessment. But that trigger for that, like, hey, I have these waveforms I readily recognize as work shifting. I've tried my mitigation efforts with increasing flow on volume. I've switched the pressure. I can't mitigate work with an increase in inspiratory pressure. I need help. We need advanced. That would be the algorithm kind of stepwise down, and how, we would teach and how we would operate here, right? Like you got to call in some additional assessment tools for that, and then you get fancy. Yeah.
I'm just going to pop this comment from Troy on the screen because I agree. Respiratory rate, not just respiratory rate, but respiratory rate and tidal volume are actually not very good surrogates for patient effort. You would assume tidal volume would be, but you can have patients with very, mild effort generating extremely. I mean, all of you sit there, you can all take a deep breath without using that much effort. So tidal volume is not necessarily the best surrogate for it, and respiratory rate definitely is not. And of course, all of these things are impacted by the drugs that patients are getting while mechanically ventilated as well.
Yeah.
So we can go way, way back into the 80s when Dreyfus did his strapping trial, right? He used different methods to show that pressure wasn't necessarily the indice that caused the most damage. It was tidal volume. And so while I respect what Troy said, I mean, I understand it's not always tidal volume or respiratory rate. We have volume targets with ARDS. We know what we can pinpoint. We want our tidal volumes to be between 6 and 8 mLs per kg of their ideal body weight. So do we look at that when we have non-invasive support? We can go back to the Florali trial and look at some of the patient outcomes there. Do we look at a tidal volume surrogate to say, okay, well, they're within this tidal volume on non-invasive support, or do we not put much credence into that? Again, going back to what Andy said, and there are people in the audience that are maybe paramedics or that may be pre-hospital professionals, and we know by literature that some of the things that happen in the pre-hospital setting, i.e. mechanical ventilation and some of these non-invasive support methods, they do translate into the care that happens in the ICU. So, do we again look at a tidal volume surrogate and say, well, their tidal volume is 5 mLs per kg of ideal body weight, they're safe, but their respiratory rate's 30, they're fighting a metabolic acidosis, And oh, by the way, we're probably being injurious, or the patient's being injurious to themselves by way of us, by looking at a 5 ml per kg ideal body weight and saying, oh no, they're fine. So what are the thoughts on the panel?
I would say this, John. I would say this is that, and this is something that like it just pours out of my mouth all the time. You can select the tidal volume. You absolutely can select it at the ventilator, and you can control it at 6 or ultra protect any volume that you have set. But once it leaves, and you can trace it all the way down to the carina, you can control the amount of volume, but you do not get to control where it goes, right? And so with the idea of high patient effort and pendulum, you can have a safe volume, but where that volume goes, dependent on the regional changes in that pleural pressure, you're going to pull that safe volume down into an area where you did not want it to go. Right? It had no business going, right? And so that's that whole idea of pendulum. So I don't know that surrogate, I'll just be honest, that surrogate does not make me feel warm and fuzzy when you have a patient that's spontaneously breathing, because I just, in my eye, I have an EIT pendulum going. I have Yoshida's paper. Can you pull that up? I have that. It just all goes to the dependent area, right? And so, though, a lot of those pictures were of a nice homogeneous lung that was all behaving in the same way, and the changes in pleural pressure were the same all the way across, it's just different with a heterogeneous disease. So I don't know that that volume surrogate is the safe way to go either, right? And may only serve to exacerbate that drive, right? Because it's kind of like peeling away inspiratory pressure from them, like you see this, you don't like the high volume, you peel away, and then you end up a la the adaptive pressure modes. You end up doing kind of what PRVC does to that, but you do it yourself. You pull pressure away from them, and you displace the work from the ventilator onto the patient, right?
Yeah.
Keith just subliminally hugged you when you said that about PRVC.
Yeah, I know.
No, I think that's a great explanation, and I think that's what I wanted to have offered to, folks that may not understand. Great explanation on where the tidal volume, where you can't control where it goes, as you can how much you give them, but not necessarily to where it goes. So I appreciate that, Eric. Thank you.
Yeah, and just to describe what's on the screen here, what they did in this study, again, it's pigs. You can see in the top left is a representative pig. They used EIT to basically detect where tidal volume was going. And in the area here where there's this arrow going up, so these zone 3 and zone 4, these represent the dorsal lung regions. And zone 1 and zone 2 are the ventral lung regions. And what they're showing here is that there's significant effort. So if we go up here, here's the airway pressure going up. So this is sort of the onset of effort here. And you can see there's the esophageal swing here. The I time's a little bit longer than the swing, but you can see this is when the effort is happening. Where this red line is when the effort, it goes right down to where it peaks. And in zone 1 and zone 2, despite the tidal volume you see on the ventilator going into the pig, the volume is actually being pulled out of the ventral region here, mostly zone 1. There's a little bit of a drop in zone 2, and you can see it's all going into zone 3 and zone 4. So when we consider the fact that we're looking at the tidal volume being delivered by the ventilator, even if the volume is actually saying something we're happy with, when we have the accompanying excessive effort, it could be going to a certain region of the lung, which can then worsen lung injury. So this would be another example of a patient, well, here it's a pig, but a pig-induced lung injury. It's still SILI, pig self-inflicted lung injury. But this is the idea. This is the concept. And they're demonstrating this to say, because and I have seen, and I'm sure others who have used EIT have seen Pendilift on patients, actual patients in the ICU. And this is the concern, that if the effort is strong enough that you're actually worsening lung injury, because even controlling 6 ml per kilo, if 80% of that tidal volume is going to one region of the lung. This is not how ventilation is to be intended.
So Tom, how do those dynamics change when you have a sick sepsis etiology ARDS with zones 3 and 4 both consolidated? How does that energy dynamic change then?
I mean, at that point, you're still delivering tidal volume to a specific area, again, the healthy lung. And this is the problematic that if you can't open the areas that are collapsed and consolidated and maintain them open with PEEP, you can constantly ventilate the healthy regions, therefore facilitating lung injury in the areas that you hope to save or protect. So we assume we're using protective ventilation, but this is really where I think EIT shines, is that you get an idea of where this volume is going when I'm ventilating a patient. And so when you have a lot of collapse and consolidation that cannot be opened with the application of PEEP, then you can visually see that this 6 mils per kilo going to one region. Now, whether or not you can reduce that tidal volume is a whole nother discussion, because if you're only ventilating one area of the lung with 6 mils per kilo, lowering it's going to make your gas exchange even worse, per se. Unless you reduce a significant amount of overdistension. But my guess would be if you tried to use 3 or 4 mils per kilo, like ultra protective ventilation, you're going to need to facilitate that with some CO2 removal of some sort to be able to maintain it safely. But this is a challenge. There are feasibility studies on ultra protective ventilation, but you have to be prepared to accept a significantly acidotic blood gas.
Yeah, so Eric sort of mentioned this a few minutes ago, but there's sort of been, and we're all aware of this, but sort of been a paradigm shift from back when you used to be able to walk through an ICU and, everybody was comatose. Everybody was sedated. Everybody was, many more patients were neuromuscular blocked. Nobody was getting out of bed, et cetera. And that paradigm shift has switched all the way to you walk through the ICU and 3/4 of the patients are at a rest level that they're sort of quasi agitated. My question is, and I've always had this concern about tidal volumes and how we apply that concept to people that are non-invasively ventilated. And my approach has always been that you use the word gestalt. I love that word. I'm not sure I fully know what it means, but I think that my gestalt allows me to look at a patient after 28 years of doing this and look at a patient and say, man, that patient's really working their butt off to breathe, or they're not. And so, Eric really hit that whole PRVC analogy home, where some people's knee-jerk reaction to larger tidal volumes is to reduce the support, which then shifts the work, some of the work from the ventilator to the patient. My question overall is, how do we know when to intervene? I know we've talked about esophageal pressure monitoring. We've talked about P0.1, which I've implemented into my practice. Anybody who's spontaneously breathing, I'll at least measure that once just to see sort of what we're dealing with. Occlusion pressure, EDI, EIT, all these fancy things that some people either don't have at their disposal or they don't know how to use it if they do. How do we know when to take that non-invasive ventilation patient and intubate them to protect them from themselves, or an intubated patient? How do we know when to intervene and how to intervene? We talked a little bit about ventilator induced diaphragm injury and how both under support of that patient causes diaphragm injury and diaphragm remodeling, and under support does and over support does. But the under support also not only causes diaphragm remodeling, but also causes potentially SILI. So even if we don't have, let's say we do have numbers. Let's say this theoretical patient that we go in, they look like they're working hard to breathe. We do a P0.1 and it's 10. And we say to ourselves, okay, well, we should do something. Now, what is that something? Is it increased support on the ventilator? Is that your first avenue approach? Is it to increase the sedation, which we know the paradigm shift is you're going to get a lot of pushback from people, from ICU staff when you want to double the propofol infusion or whatever it is. What are your guys' thoughts on the bedside clinician looking at the patient? Maybe they can do something simple like do the P0.1 and it's elevated. What's their next step?
I personally would just like to make a quick comment about that. I think one of the things that a lot of us do is we kind of look at trends in the patient's clinical status, whether we're following those numbers or we're looking at the patient. I feel like many times they either look like they're getting better or they're getting worse. And I mean, I just think that sometimes we just use sort of the big picture. And, if these little, clues are telling us that the patient is starting to get better by taking these measurements or just observing their work of breathing, I think that kind of helps guide those decisions.
Yeah, I agree with all that.
Yeah, you never want to take just a snapshot. You always want to see where your patient's going. If you walk in the room, the patient's breathing hard, but they were just put through a turn. You might want to wait a little bit before intervening too much. Sorry, go ahead.
Go ahead, Tom.
Oh, I was just going to say I threw this slide up because this was the answer to the question that I would have given. I was just going to say we can ask the experts what they would do. This is an editorial. This is an editorial by Dr. Ewan Gallagher, Felipe Damiani, and Bhakti Patel, and just saying what are things that we can do. And of course, the first potential option is titrating inspiratory support and or flow. If you're using volume assist control, for example, and I see, did Eric come back on? I think Eric might have dropped out there. Gotcha. I had to put a balloon in somebody. If you're using volume assist control, I worked in a center that it was using exclusively volume assist control, and every adult patient on volume assist control had a flow set between 50 and 60. And many people that I had known that used volume assist control prior to me working at this center, I used to hear people setting flows of 30 to 40. And of course, those flow rates will give you a lower peak pressure, which again is just resistant. It's a product of the flow. So by using flows of 50 or 60, your peak pressure goes up. That's just a product because it's flow multiplied. It's not the patient, it's your settings, and it's perfectly acceptable. However, if you're using low flows on a volume targeted mode and you're not ready to switch the patient over to a pressure targeted mode, just ensure that you're giving a flow that is at least 50 or 60 liters per minute for an adult patient. And then the titrating of inspiratory support, the question is to what extent? Many articles will suggest up to 8 mils per kilogram of predicted body weight. Every ARDS study, when someone's acidotic, it says increase tidal volume to a maximum of 8 mils per kilo. I know we're so fixated on 6, but if your patient is having significant signs of increased effort or excessive effort, then of course allowing them to take 8 mils per kilo would be ideal. Titrating PEEP is another thing. There's a paper also by Takeshi Yoshida showing the response. It's in an animal model showing the response to PEEP in terms of the effort. Next would be increasing FiO2. So there's a number of old physiology studies that shows the response to patient effort when oxygen is titrated for different saturation targets. And this was one of the most frustrating things I would say during COVID is that we would get orders on patients to keep the sats between 88 and 92 on a patient who's on 50 or 40% FiO2. And we, just because they've been ventilated for a while, they say, well, let's target 88 to 92. And the minute you do that, the respiratory rate would significantly go up. We're talking like 10 to 15 breaths per minute. And just by increasing FiO2 enough to get the sats closer to 98 the patient's respiratory rate would significantly drop, as would their effort. Their P0.1 would also drop. So, don't consider FiO2 something that can't impact effort as it can. And then fourth on the list there, for those that can see it, I know it might be small. I can probably zoom in a little bit. There we go. And Keith, you mentioned propofol, obviously. But when it comes to sedation, it's important to understand that opioids actually reduce respiratory rate, but they don't decrease drive. I mean, if you give enough of them, sure, you'll knock out a drive. But opioids in general will lower respiratory rate, but can either maintain or even increase drive. And I'll say this word, and I bet you all of you understand what I'm talking about, but I call it morphine breathing. And it's that low respiratory rate, really high tidal volume that I guarantee we've all seen at some point. And so opioids, again, they reduce the rate, but a lot of the time you end up with higher tidal volumes because the effort is not decreasing at all. Propofol is more likely to reduce that drive. But of course, there's, you have to be certain that you're not overdoing it with the propofol. And of course, if you have patients on extracorporeal life support that you're trying to transition over, using the sweep gas flow for your advantage is also helpful. There's a comment from Troy here we can say. So if we over-assist our mechanically ventilated patients, which I think routinely happens to a larger percentage of our patients, that certainty may be causing injury, but the onus is on us and not the patient. Sorry, I'm gonna have to reread that. I read it too quickly. So I think this is going to add to with the next point that I was going to be making, that sometimes we may over-assist a patient. And over-assistance is not just with the ventilator. Again, drugs, over-assisting the patients in terms of like over-sedating the patients is also a concern. So over-assisting a patient can facilitate lung injury, yes. But we have to sort of make sure that the effort is not there or excessive. The onus is on us, not the patient, so may not fit into P. I'm having trouble understanding this question, Troy. I reread it now twice. But what I was going to get to, and this comes down to solution. While Troy helps me understand his question, one of the things with solutions is that, let's say we recognize that they have high effort, even without any tools, we're concerned with the effort. The solution is always to try to manipulate the ventilator the way that you can before you move to things like suggesting increasing propofol. And of course, if they're not on VV ECMO, the last point that I made on that last slide means nothing. But before we suggest increasing sedation on a patient or possibly neuromuscular blocking agents, we really have to ask ourselves, is their effort truly injurious? And this is where it comes right back to, we said many of the studies have to do with animal models. The physiology concept is there. The theory is there. But what we don't know is whether or not intervening, for example, with drugs. We know there's a harm in over-sedating patients and paralyzing patients. We know that atrophy is a huge problem on one end of the spectrum. We know that excessive effort could possibly cause some diaphragm myotrauma, but also could facilitate the patient's self-inflicted lung injury that we've been talking about. But we don't know which is worse at this point. And this is where further studies need to address this, is that if we have a patient with excessive effort, are we better off letting her rip, or are we better off controlling it with drugs? And this is the question that needs to be answered, because we already know there's a harm with over-sedating. We got prolonged mechanical ventilation. We got atrophy. And so, intervening with a drug standpoint should be the last ditch effort, and obviously is a conversation with the whole team. But we also don't have the evidence right now to tell us whether or not letting excessive effort go forward or intervening is actually beneficial. We have a feasibility study that was done in patients on VV ECMO that they were able, and I'll show it in just a moment, they were able to get people into a lung and diaphragm protective ventilation strategy, or I should say more patients into a lung and diaphragm protective strategy by just manipulating the ventilator. And then they had to go even further for many other patients. But we still, we don't have a lot of data in terms of, again, one study on feasibility. We need more data in terms of actual outcomes. Okay. So
I'm sorry, Tom, just to kind of help with Troy.
Yeah.
Oh, Troy just came back. Okay. I mean, basically I think he's saying this is kind of more practitioner inflicted lung injury because of our over support of the patient.
I agree.
And where the patient may in fact be getting injured at the hand of us.
Yeah. Now, there's a possibility that both could happen. Like, they're not mutually exclusive. So, for example, if you over support a patient, let's say you increase someone's support and their drive does not decrease, if it still stays the same, then you are, again, facilitating lung injury, but it's the pressure you're increasing because they're not changing their effort. And sometimes it may not be beneficial. I'll give an example. If you have the patient with a pressure of 10 and negative 15, if you go up to 15 and they go down to negative 10, you still have the same, like there's still the same outcome in terms of transpulmonary pressure. So sometimes increasing the support, the patient may reduce drive, but you haven't really gotten anywhere in terms of the minimizing of the transpulmonary distending pressure.
I think to go kind of what Keith said too, he brought up the septic patient. And I think it's important that we recognize that, not all of these patients are respiratory failure patients. That's a very simplistic approach to say, well, my patient's respiratory failure, I'm gonna put him on a ventilator, we'll do this, we'll do that. I got a balloon I'm gonna drop. Septic patients, different etiologies present differently, and they carry other indices with them that we want to measure, like hemodynamic status, like FiO2, and like some of the other things that we look at big picture on a critically injured or critically sick patient, that we can't just sit here and say, we can't just sit here and look at respiratory failure. And I go back to a paper that Gail Drescher and I forgot the other physician, I think he's from Egypt, but I think they're from MedStar. And I want to bring this up with Eric, but this is pre-COVID, but she looked at septic patients and non-invasive ventilation and how many of those patients failed. It was over 50%. But there were other things that they were looking at. And I just wonder, again, speaking for some of my pre-hospital folks, how they interpret, like he said, when do you pull that trigger? When do you say, am I being injurious to this patient based on the non-invasive support that I'm giving them? Or are there other things that we look at or that they should be looking at if, in fact, they've got a 3 or 4 hour ground transport and they say, man, I'm going to have to take this cat's airway. How do I interpret that? So I guess I'm just looking at big picture and offering different insights to different etiologies that are going to require non-invasive respiratory support. Mm-hmm. And the fact that we don't hurt them or that, anyone else doesn't hurt their patient.
Yeah, I think back to what Keith mentioned earlier, specifically with non-invasive ventilation, and I think the score has even been updated for high flow, but the HACOR score initially was released for hypoxemic respiratory failure patients, but then they also published a paper on hypercarbic respiratory failure. So you kind of, again, although all patients may not be respiratory failure, generally if they need assistance with ventilation, it's one of those two problems, right? It's either oxygen-based or CO2-based. So the HACOR score is something that, what I like about the score is that, and the publications both use this threshold, but they provide a value at 1 hour that can predict with good accuracy failure. So the thing to remember with non-invasive ventilation is that success of non-invasive ventilation is not, it's not measured in days, it's measured in hours. Sure. And few hours. It's not. So if your patient's not improving on non-invasive ventilation after 4 or 5, 6 hours, they're likely going to fail. The improvement should occur within 1 to 4 hours. You should see signs of improvement, even a reduction in the HACOR score, for example. So I'll find some of the references and post them in the comments now that we're wrapping up. But I think that's one thing that I think as RTs, we should be more aware of these scores. Again, I will add the point that one single score will never make the decision whether or not to intubate somebody. Like, if you say, oh, my HACOR is 5, we should intubate, they're going to say, hold on a second. That's one value, one score. There's obviously more to consider, but these scores are considerably accurate at predicting failure. And it's the same with the ROCs. Many people that use the ROCs index, everyone says no one decides to intubate based on one score. It's more of a holistic approach. So you have a bad HACOR or a bad ROCs index. Now, what else are we considering here? The age of the patient, any pre-existing conditions, comorbidities, all of these things play a role into how severe this patient is in terms of their failure possibility.
Yeah, and the other thing I want to mention too is like the metabolic acidosis patient who's on 6 liters or even 4 liters, right? And their PO2 is fine. You don't define them yet as hypoxemic respiratory failure, but they're profoundly acidotic secondary to a metabolic cause, whether it's sepsis, whether it's DKA, whether it's something else. But then you have a physician that says, "Well, let's put them on non-invasive," because they hope to obviously correct the acidosis with that tool. And of course, there obviously are things that come with that tool, and that would be hurting your patient's lungs with a non-invasive device. And there's other ways to go about this. And I think as practitioners, be advocates for your patients and have conversations with physicians that want to correct an acidosis simply by putting your patient on non-invasive 15/5 and seeing what happens.
Yep.
I think one last thing, and I know we're wrapping up here, but John, to expand on what you were saying, I think too, it becomes very tricky when you're managing the patient you just described, because sure, some of the interventions that we might do to try to support them taking these huge tidal volumes and creating a massive ventilatory effort, that's actually done for a bigger problem, because they're certainly going to have multi-organ failure if we don't do something to support and or correct the acidosis. That may come at the expense of something else in the short term, but I think in that case, I think you still want to treat the bigger problem, because a pretty smart guy named Brady Scott told me one time, critical care is really easy. You just pick the thing that's going to kill them first and you treat that, and then you move on to the next thing. So and quite honestly, that's a pretty good rule to live by. And in that case of the patient you're describing, I think that the organ failure from the acidosis has probably got the potential to kill them faster than the SILI that may be created on the backside. So as clinicians, I think you need to kind of keep the whole thing in mind, like you said, not to lose sight of the SILI, and certainly be aware of it when you can intervene on it. But in the short term, I think, be aware of the implications of the acidosis.
Yeah, big picture. For sure, Andy.
Yep.
Very complicated, people. Very complicated. So I think it's fair to say that as clinicians, as bedside clinicians, or as teachers that interact with students and bedside clinicians, that you need to do a comprehensive evaluation of the patient, find out why they're doing what they're doing. If they're tachypnic and there's something, if they're febrile, they're acidemic, they're anxious, they're whatever, and if it's neurogenic or whatever the issue is, it's important to find out why something's going on, and then find the intervention that has the best risk benefit profile for the patient, which is where the complexities come in. Like, should I give them more sedation or more opioids, knowing that these drugs, benzodiazepines, cause worse delirium and longer hospital stays, or do I intervene because I know that this patient's very likely to cause themselves more harm? And so very complicated. I appreciate everybody for tuning in today. Thank you to all the experts. Please go to our website. Of course, everything is free. We don't charge for, we don't provide CRCEs because for multiple reasons, but one is that it would cost us money to do that, and then we'd have to get that back somehow. But I think even more importantly, we love this stuff, and the people you see on the screen right now, we do this daily with each other, and we just want to share our enthusiasm and some of the experience and knowledge that and expertise that we've accumulated along the way, and we want people to join that want to do the same thing. So anyway, thank you for showing up. Madison put our website address in the comments, inspire-rt.com. Go to our website. You can go in there and recommend topics for the future. You can make comments. You can ask for us to put a panel discussion together for your department or for your class. And we'd be happy to customize a presentation for you guys and a discussion anytime that you like. So thanks again.
On that note, I want to just interrupt you and let everyone know that next month's expert panel topic is decisions in air medical transport, recognizing and managing the difficult airway. We haven't decided on the date yet, so stay tuned.
I'll add one more thing before we close. follow Keith and Madison and John and Tom on social media, specifically LinkedIn. Keith does a great job of keeping people engaged. He posts daily research topics. He posts thoughtful like chest x-ray interpretations. There's all sorts of cool stuff Keith posts that you can follow along and learn stuff daily. You don't have to hold out and wait for these discussions. You can follow him, and he does a great job of keeping his followers engaged with thoughtful critical care based topics. So highly recommend that.
Thanks, Andy. Thanks all
Awesome.
of you. Really appreciate it. Oh, and one more little tiny thing. Tom records these, so this will be available for you to use as you wish if you want to play for your staff or just review it again. So
and I think it's on your YouTube channel, so don't look for it on mine. It's on yours, right? It'll be on your
right, and I'll post it on LinkedIn for everybody that wants to see it too.
Great.
All right, thank you.
Thank you.
See you next month.